There's always this debate on should you circumcise, should you not circumcise. So under age 1, there, especially the first month of life, there is an overall, over a lifetime, reduction of urinary tract infection in males, but that percentage of reduction is very low. That have other anomalies such as kidney issues or whatnot, then under the age 1, even though there is minimal benefit to getting a urinary tract infection, then I think it's worth it. But the biggest benefit would be if you get the circumcision done under 1 month of age. And so there seemed to be a misconception that you should wait until they're 2 months, 3 months, whatnot. So my cutoff is usually around 10 pounds or 6 weeks. And why is that?
Let it's priceless, take it to the moon. Priceless, one day will be soon. Let it's priceless.
Hey everyone,
take
it's
it
your
to the
favorite
moon.
doctor, Penis King. So today we're going to talk about circumcision. I've been getting a lot of messages to discuss this. You know, there's always this debate on should you circumcise, should you not circumcise. And so hopefully I can try to clear it up. So under age 1, there, especially the first month of life, there is an overall, over a lifetime, reduction of urinary tract infection in males, but that percentage of reduction is very low. The reason why is as long as between the age of 3 and 5, if you pull back the foreskin, and there's a way to pull it back if you can't pull it back naturally, you know, you can use steroid, whatnot, then I don't think that there's really much of a difference. That's why I really don't like to do circumcision in the OR, because unless, you know, there's an obvious reason, you know, the tip of the penis, the skin is scarred or whatever it is, you know, where they can't urinate, that's different. We're talking about elective circumcisions here. And so, and then, you know, and so I don't think the risk of anesthesia is just worth doing a circumcision in the OR. That's just my thoughts, okay? That's, I don't know what other pediatric urologist thoughts are, but I think circumcisions done in the OR should only be done if there is a true medical necessity. And what would be some medical necessity? Recurrent urinary tract infection. But I think you can get around that by pulling it back and cleaning it appropriately. But you can have children that the foreskin just is a contributor to urinary tract infection and ultimately will end up getting children that have other anomalies such as kidney issues or whatnot, then under the age 1, even though there is minimal benefit to getting a urinary tract infection, then I think it's worth it. But the biggest benefit would be if you get the circumcision done under 1 month of age. And so there seemed to be a misconception that you should wait until they're 2 months, 3 months, whatnot. So my cutoff is usually around 10 pounds or 6 weeks. And why is that? Unless you're premature. And why is that? That's because when you do circumcisions in the office, there's 3 main ways of doing it. One is called the Mogan clamp, and that's like a cigar cutter. I don't like to use that because it's rare, but you can actually accidentally cut off the head of the penis. And, well, that's a problem. So the second one is a plastibell. And the plastibell, what that does is you put it on the head of the penis, and then there's a little plastic piece that the skin goes kind of over, and then you use a string to basically strangulate the skin, and then the skin eventually will fall off. Complications from that is low, but sometimes it doesn't fall off in a week or 2. Infection, you know, the device doesn't fall off, whatnot, but it's rare. And so, but it's safe in a sense that you probably won't run into bleeding and stuff much with the plastibell versus the Mogan clamp. My preferred technique is the Gomco clamp. And the Gomco is actually just a metal device that I put on the head of the penis, and then you pull the skin through the the device that comes with it, and then basically it seals the skin together. So what does it seal? It seals the interpreputial skin to the penis skin, and the interpreputial skin is that little pink skin that you see below the head of the penis. And usually when I use the Gomco clamp, I clamp it and I leave it on for about 5 minutes, and I do a penis block. I know a lot of people use dextrose. I just think kids have nerves. They do feel pain. So for me, practice pattern, I rather block them with lidocaine, so I know that they don't have pain. And then once you actually do the procedure, it's like a crush injury, right? Where, you accidentally close the door on your hand, you see how you feel numb because it crushed the nerves. Well, the penis, no difference. Once the clamp is engaged and it clamps the two skin together, then basically the baby's really not going to have pain after that. And so then after that, I just cut the skin off, and then I undo the device, and what you see is what you get. And that's why I like the Gomco. Now, the Gomco does have a risk of skin separation, especially when you're older, and that's why my cutoff is 6 weeks or 10 pounds, because I think it has to do with how soft the skin is. The younger you are, the softer the skin. The older you are, the rougher the skin. And so if you're above 10 pounds or above 6 weeks, I do it on case by case, just because last thing I want is separation. Now, there are things we can do to try to help prevent that, such as using Dermabond, which is a glue, or preemptively putting in sutures. But I rather not use any of that. And so for me, and plus the benefit really is the first month of life, right? And so if you're going to get a circumcision, you shouldn't wait until 3 or 4 months and then go get it. Now, if you're severely premature, then that's a different story. Then, it'll take time for you to gain weight. The skin probably still soft. So I go case by case. If I look at it and the skin look rough, or there's a rash on it or whatnot, then I just won't do it. And I'll tell the parents, I just think the risk of bleeding doesn't outweigh the benefit of the circumcision. And keep in mind, little children or little babies don't have a lot of blood reserve. You lose a little bit, and that little bit can land the patient in the hospital with a transfusion. And then when you do the circumcision, regardless of the technique, parents are not told. And that's why when I do the circumcision, I always, when I used to work for a hospital system, I was doing 80 to 100 a month. And the nurses who know me know it was crazy. It caused so much arthritis in my finger that I had to quit, because, I didn't train 9 years after med school to do circumcision. But since I was working for a hospital system, then, I have to do what I needed to do. But it was just horrible. It just caused a lot of arthritis. And I think to this day, I still have some arthritis. That's why I really steer away from circumcisions. But I will do it for special exceptions or whatnot. And so, but for me, I have an actual video that I have patients watch, because if you do the circumcision, after about 2 weeks, pulling the skin back, or else you're going to end up with adhesions. And I spoke about adhesions in another video, so, I won't dwell too much on that. But if you have adhesions, basically, eventually that'll form into skin bridges, and then you just bought a procedure. Now, when they're young, I can cut the skin bridges in the office, but I'd rather not have to do anything. And so my practice pattern is, if I do a circumcision, then I see them back in 6 weeks to make sure parents kind of pull the skin back the best they can. Now, what are some of the other benefits? Typically, penile cancer, which is ultra rare in the first place, is really only seen in patients that are uncircumcised, and I think that has to do with being able to clean it appropriately. So I think if you're uncircumcised but you're able to pull the foreskin back and clean it at a young age, which usually between age 3 and 5 is when I recommend you start cleaning it, then I think your penile cancer rate is going to be the same as someone who is circumcised. The third benefit is it does have some protection against some sexually transmitted disease. However, we're really not in a high disease HIV transmitting area, right? So if you're in a high HIV transmitting area and, condoms aren't used or whatnot, then, the less of the two evil is the circumcision. And so, but I think, I don't want people to get this misconception that, if I get a circumcision later on, I don't need to use a condom because it'll protect me against certain sexually transmitted disease. And so the biggest take that I want everyone to get from this really is really parental preference, whether you get a circumcision or not. And if you do get a circumcision, I recommend you get it within the first month of life, where you will see the most benefit from a urinary tract standpoint. The only time that I kind of feel strongly about circumcision is if you have other urologic anomaly such as vesicoureteral reflux or obstruction of the kidney, where you really do want to try to do everything possible to decrease the risk of urinary tract infection with low dose antibiotics, and circumcision is part of that game plan. And that's probably the only time that I would maybe convince parents probably circumcision may be something to consider. But I don't really push parents very hard on circumcision because, like I said, I think circumcision is a parental decision. If parents want it, great. I think it should be done in the hospital, just because if there's any bleeding or whatnot, put a suture in or glue it, or there's multiple ways of stopping it. Versus if you do it in an office and they're not trained to really put sutures in or other techniques to stop the bleeding, then really the only thing they can do, which is very acceptable, is if you don't feel comfortable putting in sutures and all that, the best thing to do is hold pressure. Just wrap a Vaseline gauze around it and some Coban, which is just a stretchy type tape, and you put pressure. Because where you usually bleed is if the skin separates or underneath the head of the penis on the underside, there's always a frenular artery that can bleed. But since children's blood pressure is really not that high, typically after 2 minutes, the bleeding will stop. But the key is, do whatever it takes to stop the bleeding, because children just don't have a lot of blood reserve. And so that's kind of the risk and benefit of a circumcision, and then that's just my thoughts, okay? So I don't know what other pediatric urologists' thoughts are, but for me, if I take patients to the OR, I always have to ask myself, does the benefit of what I'm doing going to outweigh the risk of anesthesia? Even though the risk of anesthesia is low. For two reasons. One is I'm the only urologist, and Memorial City is the only hospital in the city that I know of, probably in the state of Texas, that we do something called spinal anesthesia. So if a surgery is below 90 to 120 minutes, and since I fix mainly genitalia, but we've done hernias and laparoscopy with spinal anesthesia, where literally we really don't put the patient to sleep. It's kind of like a spinal tap. So for those who don't know what a spinal tap is, it's similar to an epidural except much safer. And so just imagine what a spinal tap really is let's say you have a child with high fever, you take them to the ER. One of the things they're going to do is rule out meningitis. Not in all situations, but a lot of situations. Just from asking my ER friends, I'm not an ER physician, so I can't attest to the data on that. But when you have FUO, which is fever of unknown origin, then they'll test everything. And one of the things, if they're suspicious that there may be meningitis, what they do is at the spine level, at the very low and kind of where the pelvic brim, if you make a cross line across the pelvic brim, they literally would just tap it in there and to withdraw the CSF fluid. And so with spinal anesthesia, that's exactly what they're doing. But instead of withdrawing CSF fluid, they would put numbing medication in there, and then sometimes they'll put some clonidine to keep the medication in there a little bit longer. We've done probably over 500 spinal cases, and our complication rate, to be honest with you, is 0. And so once parents read about spinal anesthesia, pretty much in my population anyway, 100% of them want spinal anesthesia because nobody likes the idea of putting their patients to sleep. But putting their child to sleep. But keep in mind that 99% of children's surgery are performed traditionally with either a intubation or laryngeal mask anesthesia. And obviously I've done thousands, and the complication rate from that is also very low. But if you if you can eliminate airway risk, why not? And real briefly, how spinal anesthesia even started, because I'm going to give credit to where credit's due. So when I used to work for a hospital system a few years ago, the FDA came out with a kind of a warning. But if you read the asterisk, it does tell you, like, don't delay surgery based on what they're saying. But what the FDA is saying is if a child under age 2 has a surgery that's 3 or more hours, or if he or she has 2 or more surgeries, key is in animal studies, not human studies, there may be a link to learning disability, but there is no human literature that supports that, and they acknowledge that. And so I think that is really geared more towards because in children, when you do MRI, you have to put them to sleep, is just for the physician to really make sure, like, when they order a test that requires a child to be put to sleep, or even a surgery that requires a child to be put to sleep, really, make sure that the benefit of that test outweighs, this theoretical risk. But I just want to reiterate that I'm not suggesting that you delay surgery based on animal studies, because even the FDA says that don't delay surgery based on animal studies, because there's no human studies. Now, I know they're trying to do human studies right now, but as of right now, we just don't have any human studies to justify that. And so if you're a surgeon, if they do surgery with, laryngeal mask anesthesia or intubation, then, just don't let what I just told you scare you. But the reason why we started spinal anesthesia was because of that. And then if you notice around the nation around that time, because I have a friend up in the Mayo Clinic, and he told me the same thing. Once the FDA comes out with that, nowadays people really don't read the whole thing. They kind of just read headlines. And so they kind of, there was a push for spinal anesthesia, but not a lot of trained anesthesiologists can really do a good job, because it seems easy, right? But it's, I'm not an anesthesiologist, but I've seen a lot, and it's not as easy as it sounds. Because how they do it is they would put some numbing cream on so that the child doesn't feel the needle when they put it in, and then they give something called Presidex to kind of just calm the child down. And then the clock count, the 90 to 120 minute counts when you actually inject the needle and you inject the medication. Because now you have to consider, because after that is when they start to put IVs in, they have to prep the baby, we have to swaddle the baby. And so the baby's asleep, but not really medically induced. Now, sometimes we do go over, or, the dose may not be high enough. So I'm not an anesthesiologist, so that's not my specialty. All I need is for the baby to be still. And so there's a lot of stuff the anesthesiologist can give that can kind of help calm the baby down, because the biggest issue is they're hungry. It's not so much as they have pain, because I can tell, because their blood pressure doesn't shoot up and their legs aren't moving, and that's how you can tell that the block works. But children get hungry, and when they get hungry, there's really not much you can do except to feed them. But we don't like to feed children until I start closing, when I know that I'm not going to be coming back in, like I'm confident. And so that's why the anesthesiologist that I work with, he will only do spinal with me because we've worked together before, and he knows that I'm pretty accurate on my time. And so anyway, so that's kind of the another way of putting someone to sleep. And I don't know of any hospital that currently is doing it, but it was started when I was still with the hospital system. And that's the reason why we kind of started it, was to try to eliminate airway risk, even though airway risk is very low, but it exists. And so if you can do something that is safe, that can eliminate even one child, then why not? And I also like it because there's really no wake up period. And so the surgery and the process just so much more efficient. And the feedbacks we've gotten from parents is they actually all love it, because there's just no waking up. And so literally once they bring you to recovery, they call the parents in pretty quick to start feeding. Now, sometimes if the child's very hungry and I'm closing, then we'll feed them Pedialyte or whatnot, because I know we're not going to need to intubate. But that's kind of the history behind the push of spinal anesthesia. And so hopefully it'll catch on a little bit more, but it really boils down to, but kind of back to our main topic, I hope that kind of answers a little bit on circumcision. And so that's why you'll notice a lot of insurance after H1, they're not going to cover full circumcision, because there's just really no medical benefit at that point. Unless kid has had urinary tract infection that we can attribute to the foreskin, or balanitis. And balanitis is a form of inflammation of the head of the penis secondary to having the foreskin. And even though you pull the foreskin back, patients can still get balanitis just because of the foreskin. And really the cure for that is circumcision. And then from adults, I've heard from them where, the Texas heat's hot, they're outside, it's sweaty, don't like the smell or whatnot. But usually those patients, they'll pay cash for it, because it's just hard to get the insurance to cover a hygiene thing, but without really having the big two, I think, which is urinary tract infection or balanitis. Now, sometimes if the skin is very tight and they have tried steroid cream and they're not able to pull the foreskin back, or they're able to pull the foreskin back, but they can't pull it back up, that's called paraphimosis. Now, that's a medical emergency. So if that happens, then usually, depending on which hospital you go to, they may perform the circumcision there and then, or they may just do something called a dorsal slit. And with a dorsal slit, you can do at the bedside with just blocking the penile nerve and then basically making an incision on the back skin to allow the skin to be pulled forward. And the reason why you don't want paraphimosis is it can actually choke off the penis and cause some damage. And so when I tell patients to start pulling the foreskin down, I tell them just pull it down after steroid use. After a couple weeks, just start pulling it down a little bit each day, and then I bring them back in about 6 weeks or so that I can assess to see if it can truly be pulled back. Because the last thing I want is parents or patients is aggressive about pulling it back, and then you end up choking off the penis. And so I hope that helps parents and patients decide, if circumcision is something that they want to do. But, I just want to close with this. Biggest reason why patients or parents have their son circumcised is really a cultural thing, not so much as a medical thing. And so, there is some medical benefit, which I just talked about, but the medical benefit is so small that I don't think it justifies doing the circumcision to get the medical benefit. And keep in mind that this is my opinion, but this is database, and so that's why the American Academy of Pediatrics, their stance is still there's benefit to circumcision. However, in bold, the biggest reason is parental preference or patient preference, and not so much as the medical benefit. Because keep in mind, circumcision is not a benign procedure, right? You can get bleeding, you can get separation. What if the patient has an underlying penile disorder and then you circumcise the patient, which I see a lot. And then they come see me because the penis doesn't look right. And now when I try to correct it, I don't have any skin to cover the correction. And so you kind of have to bear that in mind, that when it comes to circumcision, just make sure that if you do choose to do it, just make sure that the penis absolutely looks normal and there's just no abnormalities associated whatsoever. Because if there is even an inkling of an abnormality, my suggestion is seek a professional who deals with penis, because more than likely that professional can do the circumcision in the office. The circumcision doesn't need to be done in the hospital, but I recommend most circumcisions, because most are going to have a normal penis, be done in the circumcision. Have the circumcision done in the hospital, just because you're not going to find a lot of people or a lot of doctors who perform circumcisions as an outpatient. And then by the time you get in to see them, the child probably is already 2 months old, 3 months old, or whatnot. And then now, like I said, I don't think the benefit of the circumcision outweighs the risk of going to the OR. And so, and I'm very straightforward. I tell parents what I think. And then, if parents really adamantly wants it, then, we can do it. But I really do seriously talk to them about really thinking about, do you really need to do this? Because if you keep proper hygiene and all that, and later on, teach them about good protection and all that, then I don't think you're going to have patients that are uncircumcised will have an increased risk of penile cancer, sexually transmitted disease, and the protection from the urinary tract infection is just so low that it just, the risk of anesthesia, I just don't think justifies it. So I hope that helps any parents or patients who's thinking about a circumcision. And then I'll leave with this. If you look at the penis and it just does not look right in any way, form, or fashion, the last thing you want is for someone to take off the foreskin. Because keep in mind, once you take it off, you can't put it back on. And so if you take it off and then it doesn't look right, and then you come see a penis surgeon to try to get it corrected, the biggest problem I always encounter is skin. Where am I going to get skin? And a lot of people have asked, well, Dr. Pham, can't you just take a skin graft from the leg or whatnot? And the answer is no. The reason why is, just imagine your face. If you got a cut and they take a skin graft from your leg and they put it on your face, it's not going to look the same, and you can't put makeup on a penis. I mean, I guess you could, but you get you get the gist, what I'm trying to get at. And so, but I'll leave you with this funny story. So I saw a patient recently who actually was going to get a circumcision because of hygiene reasons. But he knew a patient who had a surgery with me who told him, hey, before you get circumcised, go see Dr. Pham, because, I made the mistake of getting a circumcision before I went to see him, and I still liked the results, but it could have been better. And so he came and saw me, and I looked at it, and he still had all this skin. So I told him, I said, I try to build good rapport with the patient, so I make him feel comfortable and all that. And so I tell this patient, I said, wow, I think you're going to be very happy. And he goes, why is that, doctor? And I said, because you are not circumcised. And now I have all this skin to work with. And so this patient, who's his friend, texts me and go, hey, what did you put in patient X's head? Because he's running around the office, which he hadn't had his surgery yet. He's already telling everyone he's half black. And I just went, oh my God. And so he said, what did you tell him? Because he's thinking that he's going to come out with 9-inch. And so I text, he was a patient. Now he's a buddy. I text him. I said, hey, well, he may come out with a 9-inch. And my buddy went, man, why do I always get short, no pun intended. Why do I always get shafted in life? Because it just cracks me up. And so I told him, I said, you never know, he may come out with 9-inch. So, but if you like the content, click the word subscribe, follow me on Instagram, Facebook. I know a lot of you guys already follow me on Facebook, but it's going to be D-Talk with Dr. Pham. Podcasts on Spotify, Twitter, Apple, whatever social media platform. Subscribe and like, and I'll keep doing these educational videos. And if there is a topic that you do enjoy or you want me to discuss, like I said in the first episode, if I'm not an expert in it, I will bring someone who is. And keep in mind, this show is really meant purely to educate men. And if there are some women disease that we deal with urologically, and so when that episode comes up, then we'll talk about that. But anything from wealth management to real estate, whatever you want, you let me know, and I can bring philanthropy, you name it. And so, because the plan is I'm going to bring guests on here, because you don't want to hear about urology all day, right? That's boring. The stream team is fun here and there, but really this show is really to educate people in general, even though it has a little bit of a gear towards men just because of what I do, which is I'm a brain surgeon for men. But if you have a topic, let's say about whole life versus term life versus whatever, my wife is plotting to kill me, whatever it may be, I can bring a detective on here. I can bring financial advisors on here that can give you generic advice and all that. And, one of the things I'm hoping to do, we'll see how this goes, but we'll do it where we'll let people call in live with questions. If it's a guest that they have a particular question about. So this is Dr. Pham, otherwise known as the Penis King, signing out. So until next time.
We gon' do it like it's priceless. Take it to the moon. Priceless. One day will be soon. Like it's priceless.